The next talk, I will talk on behalf of my colleague, Ugo Angeloni, who really spent the last months to get Circare software work properly in our center. This went across trying calls with all the Circare group and finally to have good results. So today I will present you our real-life experience. I will present you some cases and also what is our idea on how Circare should be used both in clinical field and in research field. So yes, Ugo is first he was a neurologist, then he became a radiologist, neuroradiologist, and also a pediatric neuroradiologist. Okay, what is the background briefly? In the hyperacute phase, most of RCT use the rapid system, which allowed us to extend the time window for ischemic stroke. But at the same time, what we know about perfusion came from PET and SPECT studies, which actually showed that maybe this time window could be even after 24 hours. And so, yeah, basically some studies showed what is important is here, that with PET we can see still some zone of, in the border zone, in fact, we can still some vital tissue up to 48 hours, up to 42 hours. So maybe in some selected group we can still have a penumbra beyond 24 hours. Circare. What are the potential benefits of Circare? We have both hemodynamic and metabolic data, and this could help us in a rapid decision making, as well as a better definition of the impact, which is, I think, the mainstay of this software. Maybe also to enlarge the therapeutic window, and also to identify new targets for new therapies. That's why we were interested on trying it in our center. So our experience, we work in a comprehensive stroke center, and after setting up the correct work of Circare in our packs, we tested it in some of our old cases and new cases, about more than 200 cases, how it works practically in our center. So from the packs, we send all the perfusion imaging, the ADC for and DY if it's an MRI, to Circare and Circare console. So we have two destinations. Then after the result, we'll have two different results. The hemodynamic result will go to the PACS, so everybody can see it. And the metabolic one, right now we can see it just in Circare. We wanted this because it could be a legal problem in Italy, actually, to have metabolic data in the PACS nowadays, because we still don't know how to interpret that. So for the moment, we have this metabolic data just in the Circare console. So, as I said, we have a clinical part and a research part. But now let's see some of our cases. First, we see a M1 occlusion. This is an MRI, and this is what we normally use. You can see that there are artifacts in the cerebellum. It's an M1 occlusion, so it's a little bit overestimating. This is Circare. Oh, sorry, the video. Yeah. are not working properly. So this was CERCARE, which gave us this better definition. We didn't have that cerebellar artifact. We can have on the PACS also the Tmax maps, which could interest the neuroradiologist. And we obtained also to have the maps with a different threshold of Tmax, which is important for us to understand if we're talking about penumbra, oligoemia, and so on. These are not working video, but these were the what we get in the console, so the OEF and the CTH. And this is the final hypoperfusion volume defined, not just considering Tmax, but all the hemodynamic data we have. Okay, this is the post-treatment. And this was the lesion. We tested it also in CT, in CT perfusion. So RAPID told us there was no core. This happens quite frequently in our center, that we have this infinite mismatch, full mismatch. So we have a big hypoperfusion volume according to RAPID and no core as defined from RAPID. While CERCARE could detect also this little CBF deficit, just 9 milliliter, but still important to see that there is some core and is not just hypoperfusion. And this is the final core hypoperfusion definition, considering not just the Tmax, but all the hemodynamic data, so the AI hypoperfusion defined, and this is post-treatment. The patient had also contralateral hemorrhage, but this has nothing to do with the recanalization. The real impact was here, and that's what it was detected by the post-treatment perfusion. Oh, these are working, I hope. Still not, sorry. Now let's see a distal occlusion, which are maybe the patient in which will be most important perfusion in the future. It's not always easy to see a distal occlusion, and moreover, we don't know if to recanalize MIVO is effective. There are ongoing trials. We will see if they will be effective, but we tend to forget that stroke is not just opening a vessel, it's saving penumbra. So maybe before opening this distal vessel, we should know if there is actually some penumbra to save. This was the M3 occlusion with this area of hypoperfusion, really tiny core. We obtained also all the Tmax threshold maps, and this was the final result. And I hope this works. Yes, okay. You can see reduced OEF. And the CTH also is not working, but was increased actually. Sorry for these videos. And then let's see some posterior circulation. We normally don't trust to CT perfusion in posterior circulation. We have the possibility to perform MRI. So whenever we can, we use MRI. But still, it's important to know to have a good perfusion imaging on CT, also for posterior circulation. So this was the rapid evaluation of this basilar occlusion with different Tmax thresholds. No core according to the rapid. And this was Serker. So Serker saw some tiny infarcts. I don't know if it's visible. Some tiny ear core. And the real area of hypoperfusion is the yellow one. So you can see it better here. The yellow one is the hypoperfusion detected. And in the end, the patient had some cerebellar and pons lesion. Finally, posterior cerebral artery occlusion. We have in our packs both maps of cerebral blood volume, cerebral blood flow, Tmax, with different thresholds, with the possibility of having the maps, which is most interesting for the radiologist, also to understand if what we get in the end correspond to reality. So here we can see the reduced CBF and the prolonged Tmax in the left posterior cerebral artery territory. And this is the final evaluation. So this little area of core is the violet one with a big area of hypoperfusion. And finally, right ICA occlusion, intracranial ICA occlusion. This is the rapid. And this is the Serker. So you see, So you see it's quite comparable. Better definition of different Tmax thresholds and also of CBF. And this is the final mismatch. This is another stenosis of M1, M2 with this distal embolization. And this is the area of hypoperfusion with tiny little infarct with the maps and final elaboration of CBF and Tmax. We have both on the PACS the scrolling possibility and the horizontal maps. So this was some example of how we use it in the clinical part and how it actually seemed to be working as good as rapid, maybe better. We need a validation, that's sure. We talked about this before. What about research? We want to, we think that Serker with CTH, OEF, CMRO could be useful to study both the hyperacute phase, but also maybe the late phase, the neurogenesis that happens, we know, until 1 month after ischemic stroke, both in adults and also in newborn. So these are a list of possible suggestions for future research. So in stroke, of course, in ortho phenomenon, I talked about it, but also in TIA, maybe, in chronic ICH occlusion, in watershed infarcts. We could study also to study the relation between the capillary hypoperfusion and the prediction of final ischemic damage. And also to study the neurogenesis days after the ischemic stroke. and maybe to select a new classic of drugs, also in newborn, in the hypoxic ischemic encephalopathy of newborns. Right now we are doing a study on hypoxic ischemic damage, ischemic stroke, and neurogenesis. So we're trying to see with microRNA and free Tesla MRI, the spectroscopy, which are the components of this neurogenesis. In particular, we studied netrin 1 and semaphorin 3A. Maybe studying also the capillary part in this patient could tell us how this neurogenesis after ischemic stroke in the 1 month after works. Thank you.
Thank you very much for sharing these exciting data. Questions?
Yes, you showed a case with an infarct in the parietal lobe where you had a decreased oxygen extraction fraction.
With an infarct where? In the?
A distal infarct in the parietal lobe.
Yeah.
Showed the oxygen extraction fraction decreased and oxygen metabolism increased. Isn't that the straight opposite than what it would be?
We can see it.
Yes, the movie that worked.
Yeah, it was the.
I think you're right.
Yeah, you're right.
Well. Yeah.
You're right. But actually, these were the data that's why we have this data just on the console and we don't have it on the packs because we need to interpret them properly. But yes, it was the inverse, actually.
So I think physiologically something like that can happen if you do have a reduction in OEF, but it will still just multiply by flow. But it's very, as I said in the initial talk, it's very important to remember we don't measure flow directly. So it's a prediction based on hemodynamics.
You know, we had some experience with rapid 3 years ago, and we were quite unsatisfied with how was the detection of the intercellular hemorrhages with rapid. And it ended up when we were like doing this study, we were like looking at, you know, other different versions of the program. So for example, Rapid has a new version now comparison to 2 years ago. So what are you showing here? The differences between different programs could also be affected by which version are you running. And that's a big question in all of these commercially available softwares, which is not put as a topic at all. Because maybe with a new version of Rapid, you will get the same results.
Definitely.
There are some other vendor, for example, or if you rerun the scans from previously. So it's a very big question, which is, you obviously when you read in the papers, you can see that there's like the analysis is done with Rapid or Circare or whatever software. But the question is which is version of the software and how much that version changes from the previous one. So
but
it's just a topic too.
Yeah, it's definitely
a very important topic, which is very put on the side.
Definitely a topic, but except for the first one, the other cases I showed were cases from the last 3 months. So we had to send both Rapid and Circare. So these were the last version. Just the first case was an old one. So we send, right now we have Rapid and Circare, both. And anyway, first of all, big warning is that this experience, these cases, is not evidence-based. It's just to say our real-life experience in the last months. We need the real-life data, we need validated data, we need evidence-based. So it's just to show how we made it work, which first was not easy to set up it in our center. It took quite a long. like a couple of months to make it work, to have good maps, which is important, which can be read by everyone, not just by neuroradiologists, because in our center they are not everybody, not all the radiologists are neuroradiologists. So we need some clear maps showing what is happening. But yeah, definitely we should compare to Neuralise or Rapid. I agree.
Thank you for this presentation. What is your experience with the detection of small diffusion lesions with Sapienza software?
We saw some cases, and yeah, next step is to compare these cases. We saw some cases in which the 24-hour MRI confirmed these lacunes. But I didn't show because really I don't know still. We need to collect the data to see if really CERCARE can detect lacunes. But
because in our experience, we have a little experience in clinical prospective stroke, but we've got a few cases where the lesions were detected with CERCARE and not with Rapid.
I will say that everything is less than 2 milliliters. It's hard to detect with Rapid, of my experience, while CERCARE can detect it less than 2 millimeter with the AA-based detection. But still, we're waiting for your data.